So, good morning. I'm Jonathan Van Tam, Deputy Chief Medical Officer, Department of Health and Social Care, and welcome to this briefing from number 10 Downing Street, which is a briefing about the current epidemiological situation in England and with a focus on preparing the NHS for the next phase of this pandemic. I'm joined today by, on my right, Professor Steve Powis, Medical Director of NHS England, and on my left by Professor Jane Eddleston, who is Executive Medical Director of Manchester University's Foundation Trust. May I have the first slide, please? So I'd like to begin by showing you some data which are relevant to where we are now. If you would please focus on the top slide, which is the slide for the United Kingdom, although you will see largely the same curves and the same shapes represented for the 4 countries of the UK. You will see the number of cases by specimen date in the UK. This is without any double counting, that is to say patients who've had 2 tests. And you'll see that the data are arrayed from the 1st of February on the left through to mid-October on the right. And you'll see very clearly the first peak that corresponded to the first wave of this pandemic, which we experienced in the spring. And comparing that with the second peak, please bear in mind that this is an apples and pears comparison based on case numbers, because our testing capacity in the spring was very much lower than it is now. But the key point is that having had a rather flat summer with very low amounts of COVID positive patients in the UK, you can see that from early September there has been a marked pickup. And also be aware that the last 3 or 4 points on the graph to the extreme right-hand side are figures where the data are incomplete. So those columns are likely to go up and certainly will not go in any other direction. So this is where we are in terms of cases by date. And I want to be very clear with you that as patients become ill with COVID-19, they don't immediately go into hospital. It takes some time before they become ill enough to go into hospital. And they don't die in hospital the moment they arrive. Some, unfortunately, do die, but not instantly. And the point I'm trying to make here is that there is a lag between cases and when we see hospital admissions rise and when we see deaths rise. And so, based on the curve that's there, if I were to say to you, these are the infections we've had now, then actually the hospital admissions we have right now are related to infections we had about 3 weeks ago. And if you look on the chart 3 weeks back, you can see the hospital admissions we have now actually relate to a time when there were fewer cases of COVID-19. And what I'm trying to say here is that already with the cases that we know about, we have baked in additional hospital admissions, and sadly we also have baked in additional deaths that are now consequent upon infections that have already happened. And this is an unfortunate and difficult part of the data where we have to understand that there is this lag on the worst statistics on hospitalizations and deaths. Next slide, please. So on this next slide, I am showing you rates per 100,000 by local authority for England. And the graph on the left of the screen, the purple graph, are rates of cases, and the graph on the right-hand side are rate changes. Now, the darker colours are always the higher figures, and the figures we are trying to avoid. And if you look at, first of all, at the purple chart, I think you can see that there are now very dark areas in the northwest of England, in the northeast of England, and really a confluent dark purple colour across the northern part of the UK, extending down into the West Midlands and the East Midlands. But turning to the right-hand chart, of rather more concern, the dark brown areas indicate the latest data on where things are heating up. And dark brown clearly means things are heating up. And you can see that the reach of the dark brown colours is further south into a greater landmass across England. And in fact, I received these slides this morning. I showed very similar data to MPs and the House of Lords on Friday, and the brown chart had not extended that far south. So it has changed in a matter of just a few days, and that is clearly of concern to me. Next slide, please. Now, one of the things that has been widely and accurately reported in the media is that our resurgence of cases this autumn has been mainly in adults aged 20 to 29 years of age. And that is absolutely true. And these graphs are the same representations of case rates and changes in rate, but by people aged 60 and over. And you can see, again, that there is the spread from those younger age groups into the 60-plus age group in the northwest and the northeast. And there are rates of change in the same places, but also extending a little further south. And this is again of significant concern, as my colleagues will explain to you in more detail, because of course the elderly suffer a much worse course with COVID-19. They are admitted to hospital for longer periods, and they are more difficult to save. Next slide, please. This is my final slide, and it's a selection of heat charts. And what I'll do is I'll explain it very carefully to you, piece by piece. But what you can see is on there 9 separate heat charts for various regions of England. And if I can ask you to focus on the one in the middle, the northwest. Could you click the slide, please? This one will be the best one to help you understand what is happening. So on the x-axis, that is going from left to right, across that chart, we're moving from September the 10th on the left through to sometime in mid-October on the right. And as you go up that chart, we are moving from the 0 to 15 age bracket through 16 to 29, 30 to 44, 45 to 59, and then the top line in that block is 60 plus. And if I can invite you to cut the data vertically by eye on the left-hand side of that block, and you will see that the infection rate was initially highest in the 16 to 29-year-olds. And that, as you move to the right, just gets hotter and hotter. But as it does so, you can see the incremental creep of the infection into the next age band up, 30 to 44, followed 2 or 3 weeks later by a creep up again into the 45 to 59s, and you can now see that the 60 plus are also heating up on that chart. And the Northwest experienced all of this first, and my understanding is that that pattern is likely to be followed. You can see it in the Northeast, and you can see it in Yorkshire and Humber just beginning, but at an earlier stage. Next click, please. And that's the direction of travel in terms of the creeping of the infection up through the age bands in a given local or regional area. So that brings my slides to a conclusion. I will now pass to Professor Powis to present some further data on hospitalisation. Steve.
Thank you, Jonathan. And as you have described, rising levels of infections in the community are now leading to a rising level of hospital admissions. As a country, we can limit the impact of the virus using our 3 lines of defence. The first of these is the personal measures we all individually take to limit transmission: washing our hands, wearing masks, and keeping an appropriate distance from each other. These, along with other measures introduced by the government, such as the Rule of 6, have helped slow the transmission of the virus through the summer, as you have seen. The Test and Trace service is the vital second line of defence, identifying cases and asking people to self-isolate when they have come into contact with anyone who has tested positive. These measures are designed to stop the growth in infection, which will inevitably lead to increased hospital admissions and, unfortunately, increased deaths. Sadly, as Jonathan has shown, we are now seeing renewed growth in infection rates, with some parts of the country, such as the Northwest, particularly badly affected. And so we are now having to make greater use of our third line of defence: hospital care for those who are sickest. And of course, the UK is not alone in seeing this increase. In recent days, both the Netherlands and France have seen record highs in their daily figures for new infections, with France now seeing an average of 18,000 new cases per day. The Pasteur Institute, a respected French institute, has recently said that without new restrictions, 11,000 patients could need intensive care across France by the middle of next month. And last week in Paris, health authorities ordered hospitals to activate emergency measures to cope with fast rising cases. Around 40% of hospital intensive care beds in Paris are now occupied by COVID patients. The Spanish government has declared a state of emergency in Madrid, with over 3,000 COVID patients currently in the capital's hospitals, with around 500 in intensive care, meaning about 40% of the region's ICU beds are occupied by COVID patients. Unfortunately, we are also starting to see similar pressures building in some parts of the United Kingdom. In fact, we now have more patients in hospital with COVID-19 than we did before the government announced restrictions of March the 23rd in the spring. If I could show the first slide, please. This slide shows that as the infection rate has begun to grow across the country, as Jonathan has explained, hospital admissions have also started to rise. So you will see that this is a time series from March on the left-hand side of the chart, moving through to the beginning of October on the right. You can see the peak in the 7-day rolling average of new hospital patients in April. You will see the decline during the late spring and into the summer, but you will see that since the beginning of September, paralleling that rise in infection in the community that Jonathan has shown, we are starting to see an increased rise in hospital cases. And in the next slide, you can see in more detail that it is clear that hospital admissions are rising fastest in those areas of the country where infection rates are highest, as Jonathan has explained, particularly the Northwest, where you can see that hospital cases are accelerating the fastest and are at the highest. Now, next slide, please. As Jonathan has already said, we know that infection rates have been particularly high amongst young adults. But as he's also shown, rates are now increasing in older people too. And this is directly resulting in increased admissions in these age groups. So you can see in this slide, newly reported hospital cases by age, again, the same time series along from left to right, but split into the same sort of age bands that Jonathan showed in terms of infections. And you can see that now in the over 65s, particularly in the over 85s, we are seeing steep rises in the number of people being admitted to hospital. So the claim that without taking further action, the elderly can somehow just be fenced off from risk, I'm afraid is proving to be wishful thinking. And in the next slide, if we look in more detail, specifically at the northwest, the northeast and Yorkshire, the number of patients being treated with COVID is rising rapidly in many of our hospitals. As you can see, Liverpool University Hospitals, NHS Foundation Trust, right at the heart of where those infection rates are rising the highest, is seeing the steepest increase in its 7-day rolling average of COVID-19 patients in its beds. But you will also see that the same is happening in other hospitals in the region. So Liverpool University Hospital has the highest number of COVID-19 patients, with currently more than 250 patients with COVID in its beds. And in the last 4 weeks, hospitals in the northwest and the northeast have witnessed a 7-fold increase in COVID patients in their intensive care units. And if infections continue to rise, in just 4 more weeks, they could be treating more patients than they were during the peak of the first wave. We will shortly hear more about the situation in the northwest from my colleague, Dr. Jane Edelson, who works in Manchester Royal Infirmary. But we're not just concerned about hospital admissions. Sadly, we know that this virus is more dangerous to the old, as I have shown. But we're also learning about the long-term side effects of COVID, which can also affect the young. So these debilitating symptoms, which include breathlessness and fatigue, and are collectively known as long COVID, are becoming more apparent. So this is not just a problem for the elderly, this is a potential problem for all age groups. Now, the NHS has prepared well for this second wave, and we have learned a lot from the first wave. We have new life-saving treatments, such as dexamethasone, trialled and tested here in the NHS. We better understand the type of oxygen therapies patients need and the best ways in which to care for them and to aid their recovery. 14-day survival rates in intensive care have improved from 72% to 85% since the pandemic began. The government has worked hard to improve the supply of personal protective equipment since March, having learned what is needed from the first peak. So the Department of Health and Social Care now report that we have enough PPE stockpiled to last 4 months. We have extra funding to allow local NHS services to use independent hospitals to ensure we can continue to provide elective and planned care during any second wave. And we have plans in place so that hospitals can help each other to respond to the demand that they may see for COVID and for non-COVID services. Advances in scientific knowledge about asymptomatic transmission are helping with our infection control measures that our staff use to keep themselves and our patients safe. And more money and resource are going into the NHS 111 phone and online services, with more expert clinicians available to answer inquiries. For the first time this winter, we will also see direct booking into our emergency department, our A&Es, to keep people safe and ensure that we can direct them to be seen in the right place for their condition. But nevertheless, despite all of that, we are announcing 2 further measures today, specifically targeting those areas of the country where infection is growing the most. First, to protect our staff and our patients, we will be introducing, with tests provided by the Test and Trace Service, regular testing for staff in these high-risk areas, even when they don't have symptoms. This will help us keep staff and patients in those hospitals as safe as possible. And secondly, we have asked the Nightingale hospitals in Manchester, Sunderland and Harrogate to prepare for this next phase. They are being asked to mobilise over the next few weeks to be ready to accept patients if necessary. The support they provide and how they will be used will be up to local clinicians, whether it's for COVID-19 patients requiring ventilation, for patients recovering from COVID-19, or in order to maintain essential elective and diagnostic services for patients with conditions other than COVID-19. Finally, it is a sad truth that whilst we've done much to improve the care of those who are infected, and while scientific research continues apace, there is still no cure nor no vaccine for COVID-19. That means, sadly, as the number of those infected increases, then so will the number of people who die. And that's why the government is looking at what other measures could be introduced in the areas where infection is rising the most. As the Secretary of State for Health has said, if we do not take measures to control the spread of the virus, the death toll will be too great to bear. And if I could have my final slide, it's important to remind you of something that Jonathan said earlier, that any measures, additional measures that are put in place this week will take a number of weeks before we begin to see their benefit in hospital admissions, because of the length it takes from the point of infection to develop symptoms, and then the additional time beyond that before people become sick enough to require hospital treatment. So we should finally remind ourselves that right now and throughout the pandemic, the NHS has continued to treat thousands of patients with and without COVID-19. Whilst we've cared for more than 110,000 inpatients with the virus, we've also provided cancer treatment for more than 200,000 patients. During the last 7 months, there have been 123 million GP appointments. Every day, an average 1,800 babies have been born in the NHS, and we've conducted 10 million urgent tests and checks. Even at the height of the first wave, when nearly 20,000 people were in hospital with COVID, more than double that number were being cared for in hospital for other conditions. But it remains the case that we asked some people in the first wave to wait longer for their operations, as staff had to be diverted to battle COVID-19. Where we can, we don't want this to happen again this time. But that depends on all of us doing what needs to be done to contain this virus in the community. We also want you to help us, help you stay healthy and get the care you need. So, as I've said throughout this pandemic, please use NHS services if you need them for your health needs. Contact your GP if you're worried about cancer symptoms, an unusual lump, for example, or blood in your urine. Use the emergency service if you have chest pain or another acute condition. If you're unsure about where to go, seek advice through the 111 services, through our GPs, or through pharmacists. But the key is that we must tackle this increase in COVID-19 infections so that we do not impact on the services that the NHS provides. The NHS is here to protect you from ill health. Now, as I've described, one of the areas seeing most increase in the rate of COVID infections is Greater Manchester. And that's why we've asked Dr. Jane Edelston to be here. Jane works in Manchester Royal Infirmary and leads the network of intensive care doctors in that area, and she's here to give us an impression of what's going on at the front line. Jane.
Thank you, Steve. Good morning. I'm a consultant in intensive care medicine and have been for 28 years, and also a clinical leader within Greater Manchester and the North West. And I'm here to share some of our experiences and identify for you what the challenging areas that we're facing at the moment. As you've seen from the slides, the North West has about 40% of all COVID cases at the moment, and this is proving to be very challenging for us. Within Greater Manchester, we have seen a threefold increase in the number of patients admitted to intensive care in the last 5 weeks, and an eightfold increase in the number of patients admitted to our hospitals. The situation at the moment is that 30% of our critical care beds are taken up with patients with COVID, and this is starting to impact on the services that we provide for other patients. We are working as a system across not just Greater Manchester but the North West to ensure that patients receive care, not just those with COVID but other conditions, receive care in COVID-secure locations. And we are doing our very best. But at the moment, 30% of our beds are occupied with patients with COVID. I stress to you the importance of us taking this disease extremely seriously. We are still finding that a quarter of patients who are admitted to intensive care still require to go on a mechanical ventilator within 24 hours of admission. This is very serious. The condition produces a very profound inflammation of the lungs, which does have serious consequences for patients. And I would ask you all to respect the virus and follow the advice that we're being given. I'll pass back now to Jonathan.
Thank you, Jane, and thank you, Steve. So you've heard from all three of us now, and if I may very rapidly summarise, we've clearly shown that the COVID situation is building nationally, particularly in the North West and the North East. Steve has emphasised that the NHS is there for everyone and not just to treat COVID, but to treat all the health problems we have and to stop us from becoming unwell. But there is nevertheless a massive collective responsibility on every citizen now to play their part in defeating this virus and getting it back under control. I think we're now going to have some questions, and Fergus Walsh from the BBC. Fergus, hello.
Yeah, hi, Jonathan. Question first for Steve Powis, which is last time the NHS coped during the first wave by cancelling non-urgent surgery and pausing a lot of cancer screening. How close are you to having to do that, especially in these hotspot areas in the northwest? And a question for Jonathan Van Tam, which is we've heard a lot that in the Liverpool we might see pubs, bars and gyms having to shut. Is there scientific evidence that will slow transmission? And if there is, can you share it with us?
Thank you, Fergus. So if I take the first question, as I said, in the first wave in April, we took a national approach to create the additional capacity that we needed everywhere to manage those patients that I described, the 20,000, over 100,000 treated in all that we saw with COVID-19. And unfortunately, that did mean that we had to stand down elective services and planned care. We have seen increased waiting times as a result, and we are really determined to get back to normal in terms of treating patients who are on those waiting lists. So we will do everything we possibly can during this second wave to ensure that we maintain those services. Now, of course, this time we can also see much more granular local pictures of how infection rates are rising, as Jonathan has shown you. And therefore, we will be taking a much more local approach in order to keep services going. And that involves hospitals helping each other, as I've said. It includes the use of the independent sector hospitals where we can, and it also might involve use of some of the Nightingale hospitals. So yes, we are beginning, as Jane has said, to see some impact on our capacity, but we are determined to keep that capacity for non-COVID services open for as long as possible. But the key to this is reducing infection rates, because it is the increase in infection rates which inevitably leads to an increased pressure in hospitalisation of COVID patients, which will inevitably lead to a pressure also on non-COVID services. So the key to this is the control of infection in the community.
So, Fergus, your question about pubs and bars, it wouldn't be right of me to preempt anything that might be said later on in the day. And from that perspective, I think I will answer that question based on first principles. And we do know that this virus, unfortunately, thrives on the thing we like most, which is human contact. And the aerobiological conditions that favour the spread of the virus are well encapsulated by the Japanese advice about the 3 C's. The first C is closed spaces, by that often with poor ventilation. The second C is crowded spaces, and the third C is close contact. And to that I would add my own emphasis on D, the duration with which you're likely to be in those spaces, and finally V, volume, the level of noise, because we do know, and we have increasingly strong evidence about shouting and singing as pressure points on the virus in terms of making the expulsion of virus-laden particles go further and the transmission therefore to become more intense. So all of those settings where the 3 C's and duration and volume may apply are areas where the virus will thrive and spread if we allow it to.